Greetings and welcome everyone to another episode on Oral Pathology Tuesdays held by Oral Pathology 360. It's truly wonderful to have you all with us for an interesting discussion on a very important topic, oral submucous fibrosis, which we know is highly relevant not just because it's oral potentially malignant disease, but because it is a very debilitating disease. Now, a few housekeeping things before we start. If you are logged in from anywhere else besides YouTube, it is fine. You can watch it from there. But if you would like to interact with us, send us messages so that we can answer your questions and see your comments. Please move on to YouTube and join in from there. Also, improve the quality or increase the quality to 720p for the display that ensures that all the slides that you see are very clear. And of course, we have participation certificates for all those who are channel members. If you are not a channel member, you can become so by clicking on the join button, which is below the video. Although this is not essential, it is only to get the certificate. Essentially, to watch the program is always free and will remain free. Now, if you are a channel member and would like to get a certificate, remember you got to attend live, you got to share a comment with us so we know you're there, and then you got to fill out the form, which is already been posted on the channel post. The link is already there, and you will be able to access it from there. So, with that, oh, yes. And we got to thank and welcome our newest members, Dr. Mekala, Dr. Ahmed, Dr. Subaru, and Dr. Deshpande. With that, let me bring in our guest for today, Dr. Karishma Desai. Yes, welcome.
Good evening,
It's so
ma'am.
lovely to have you with us.
Thank you, ma'am. It's my pleasure.
You're most welcome. So, Dr. Karishma Desai is a postdoctoral fellow at Tokyo Dental College. Her work, which she's going to be presenting here, is on mitochondria and how they affect oral submucous fibrosis. Rather than telling you all more about what she has done, I'm going to ask her to tell us directly what she would like to share.
Thank you, ma'am. So basically, this work is a part of my PhD. It was extended further when we submitted it to JDR. So those who have joined in, you'll also get to read about this in detail when we publish it in JDR, Journal of Dental Research. Coming to the topic, this, like I mentioned, it was a part of my PhD that was conducted at the KLE VK Institute of Dental Sciences under the guidance of Dr. Aga Kale, madam. And thereafter, I collaborated with Dr. Praveen Arani, and we did some part of our work at USA in his lab. And he further channelized the collaboration with Roswell Park Cancer Center. So a lot of our work is entirely based on collaborations. And in Pune, again, we collaborated with the National Institute of Virology, ICMR, where Dr. Basu Atanu Basu was very gracious enough to help us use his resources and a lot of other things to make this work possible. And this work is basically a very early attempt at understanding how mitochondria is functioning to bring about the differentiation of myofibroblasts or fibroblasts to say. And in this presentation, you learn about how different stages exist in fibroblast differentiation, how mitochondrial changes are running at an earlier time point before differentiation takes place. So you may not see time points written there, but please feel free to ask me at what point they happen in the Q&A session. So yes, please go ahead and let me know if you have questions. I hope this brings up a new avenue for research, especially in the field of OSMF, which is a very pertinent issue in the Southeast Asian countries. So, thank you.
Welcome. It's really nice to have you here. So, as usual, we shall go and watch the lecture and then come back for some questions.
Thank you, ma'am, for the very kind opportunity to present my work on oral pathology 360. So, today I'll be speaking on mitochondrial reprogramming in oral submucous fibrosis. So, why is submucous fibrosis important is because one, it's a potentially malignant disorder and it shows progressive fibrosis, which means that clinically you can see different presentations from very early um, say burning sensation to blistering to eventually a mouth opening that is so low or so reduced that it leads to inability to eat in patients, and hence it's a debilitating disorder by itself. Now, in terms of pathogenesis, ericanut has been implicated in the pathogenesis of submucous fibrosis. And amongst the various components, ericholine, which is the primary alkaloid, has been extensively studied. It is this ericholine which causes epithelial injury and juxtaepithelial inflammation. Now, in during this inflammatory changes in the microenvironment, cytokines are upregulated, of which one of the central matrix modulator, which is TGF beta, has a key role. Now, this transforming growth factor beta has been extensively studied in various organ fibrosis. It is said that based on the concentration, it has different roles in cell differentiation, proliferation, migration, collagen synthesis, and so much more. In OSMF, it has been released by both epithelial and fibroblastic cells. TGF beta functions by both canonical and non canonical pathways, of which we have predominantly heard of the canonical pathway. Now, it was back in 1971 when the understanding of myofibroblast evolved further. We came to know that there's something called as a quiescent fibroblast, which has low migratory ability, which has low ability to produce ECM, and which has very little or no stress fibers. Now, to the next step where it gets sort of pre-activated and it starts to show high ECM production. It starts to show stress fibers, and there is something called as an activated myofibroblast. This is the one which is implicated in causing fibrosis. Now, it has some ability to produce ECM, but it has abundant stress fibers. It is highly contractile. Now, in submucous fibrosis, as I previously described, there is cellular injury which causes release of cytokines. Now, these cytokines will further lead to transformation of fibroblast as we saw before, from fibroblast, quiescent ones, to activated ones, to fully functional myofibroblasts, which express alpha SMA. Now, it is this difference, or it is this myofibroblast which persists in submucous fibrosis that is responsible for the progressive nature of the disease. Now, it is said that in wound healing, after the function is done, the myofibroblast will undergo apoptosis. But in submucous fibrosis, these show some immune privilege and they survive. And hence, OSMF is also known as an aberrant wound healing process. Now, in terms of amassing, a study done by my mentors in 2011 did show that as the grade of OSMF increases, so do the ASMA positive fibroblasts increase. Now, further to understand the myofibroblast survival, we checked programmed cell death 4 protein, which is an anti-apoptotic protein, and we found that the alpha SMA positive myofibroblast also start expressing high levels of PDCD4 as the grade increases. We checked this using serial sections. So by now we know that in pathological conditions such as scars and Dupuytren's contracture and so on, ASMA positive fibroblasts or myofibroblasts persist and they have other cytoskeletal changes. So in case of contractures and scars, sometimes people have observed a VAD positive phenotype, which means that the cytoskeletal not only expresses vimentin and alpha SMA like intermediate filaments, but also desmin and in some cases even myosin. But in submucous fibrosis, what we wanted to understand is whether these phenotypes have a special role and how or what are the cellular and functional changes which are mediating this transdifferentiation and survival. For this, when we studied the literature, we found that research by Dr. Pataru Kondaya's group and Dr. Pant's group have shown us that ericholine, along with TGF beta, potentiates some of the genes that are involved in fibrosis. Now, based on this understanding and based on the clinical presentation of OSMF, we thought of having study groups that included not just ericholine and TGF beta, but a combination group, and at the same time to just study the effect of ericholine by blocking the baseline TGF beta. We created a group which is ericholine with ALK5 inhibitor of TGF beta, which is SB431542. And this inhibitor was also studied as a control along with the untreated fibroblast. Now, prior to moving ahead with the changes that take place, we wanted to assess what concentrations should we use for studying the changes. So, in this regards, when we used Alama Blue, we found that ericoline at a subtoxic dose of 50 microgram per ml is the most suitable, and this was similar to what existed in the literature. And in terms of TGF beta, now this was a bit tricky because it's a pleiotropic cytokine. So at 10 nanogram per ml was what we found as the most suitable concentration. As I mentioned before, we use the Alama blue dye. Now, in this dye, in live cells, will be changed into a highly fluorescent pink compound, as you see in the plate here. And it is then evaluated by using a Blackwell plate and a spectrophotometer. You can also stain these cells that you plate in by using crystal violet staining. Now, when we use crystal violet staining, we found that the cells in the ericoline and the TGF beta group were healthy and plump. And in case of the ericoline, they started showing cell death. So there was a sharp difference between the combination group and the ericoline treated group. Now, after understanding the dose and the survival response, the first thing that we wanted to check is whether ericoline causes release of ROS. Now, we know this chart of pathogenesis very frequently, we have studied it. And in this context, when we checked the ROS production by Amplex ultra red assay, we found that ericoline has the maximum ROS production. So clearly by now we know that ROS is increased, and we know that ROS has a lot to do with mitochondria. So now we are moving on to the mitochondrial aspect of the study. Now in terms of mitochondria, the first thing to do is to assess the membrane permeability or the health of the mitochondrial membrane using the membrane potential dye. So in JC10 assay, what happens is that this dye, which is a green colored compound, changes into an orange red compound in healthy mitochondria, and in an unhealthy mitochondria it remains as a greenish dye, which is seen by the green fluorescence here. So when we observed this in our study groups, that is the control, ericoline, TGF beta combination groups and SB, we found that ericoline group had maximum depolarized mitochondria. So the health of the mitochondria was worse in case of ericoline. But in case of the combination and TGF beta group, they were either more or similar to the control group. And alone ericoline was further making it worse for the mitochondria. Now, on assessing that the mitochondrial membrane definitely is undergoing some changes on treatment with TGF beta and ericoline, the next thing would be to understand why is mitochondria important and what could be the changes that are happening, which are depicted through these membrane depolarization changes, right? So, in this context, we know that mitochondria in a healthy cell is tubular. It helps to maintain the cell homeostasis, and whenever there is injury, whether it is mild or severe, there is some form of a dynamic change in the mitochondria. Now, this change can present as fusion, wherein two mitochondria are fusing together to reduce the expansion of mitochondrial DNA mutations. It also works towards decreasing susceptibility towards apoptosis. So, the cell is trying to compensate by these changes. And in addition to these processes, what changes in terms of the function is that the bioenergetic efficiency is going to increase. So the transcription or the energetic pathways are going to function differently in this scenario. Now, what happens when the damage is so severe that the mitochondria start to undergo fission? Now, in fission, there is, of course, increased mutations, there is increased ROS, and there is an increased susceptibility to apoptosis. So, how is this relevant to submucous fibrosis? So, when we used our study groups, and predominantly, let me show you this scenario in control, that is the human oral fibroblast cell lines that we used. The cells presented with very tubular, normal appearing mitochondria, and we used mitotracker red to stain these cells, and the nucleus here is stained by DAPI. Now, in case of the study group, that is ericoline, a distinct break in the mitochondrial structure could be seen. That is, you start seeing these punctate round mitochondria. These are very much indicative of fission, but we had to still confirm this. When we checked the TGF beta group, they started appearing elongated and at some places branched or complex. So to further study this, we used the ImageJ NIH software, and we did a structural and branch analysis. Now, this can be studied further in the paper that's going to be published by us in JDR. It's already accepted. And when we analyzed the structure and the branching, we found that in case of ericoline, they were very small round structures, but TGF beta showed branch structures. What was interesting is what happens in the next group. So in the ericoline plus TGF beta group, there is a distinct combination of these round as well as elongated branch structures. And in case of pure ericoline, where we block the TGF beta receptors, it's similar to ericoline group wherein punctate mitochondria were seen. And SB by itself did not show much change. So to interpret these findings, when you see a confocal image, you cannot directly say that this is fission or fusion. You have to analyze them using the software that I mentioned. So we studied the form factor and the aspect ratio, as well as the branching or the networking or the increase in complexity of mitochondria. And in all of these cases, we found that the ericoline plus TGF beta group had maximum branches, had maximum branch length, followed by TGF beta. They also had maximum junctions, and their form factor was high, which meant that when the form factor is more than 1, it means that it's an elongated or a branch structure. This definitely represents mitochondrial fusion. So in case of TGF beta and A plus T, we definitely found mitochondrial fusion. And in case of ericoline, it was more of rounded structures, which was studied by form factor as well as aspect ratio. Now, to further analyze the fission fusion, we had to study the markers that are universally accepted. So, in terms of fusion, MFN or mitofusion 1 and 2 are predominantly studied. And in the other thing that is studied is the optic atrophy 1 factor. These three are frequently explored in case where we are suspecting a fusion of mitochondria that is taking place. And in case of fission, DRP1 is dynamine related protein 1 is studied. So we began with an IFA and we did the IFA for MFN2, and we found that TGF beta and A plus T had more expressed more fusion compared to ericoline and control group. And in case of DRP1, this was extensive in case of the ericoline group, followed by A plus T and then TGF beta. To further confirm the fission fusion marker expressions in our submucous fibrosis groups, we conducted a Western blot experiment, and in here the optic atrophy 1 protein in terms of the long membrane bound protein as well as the short soluble protein were assessed, and we also checked for the fusion and fission inhibitors, that is MF18, which is a fusion inhibitor, and MDVI, which is a fission inhibitor. In each group, we added these inhibitors for fusion and fission, and we found distinct results which complemented those of the previous expression study, wherein ericoline showed DRP1 expression and lower LOPA expression, which meant that there is increase in the fission. And in case of TGF beta, there was increased LOPA expression and there was increased survival, as we also saw by the cell viability assay. And this meant that TGF beta inhibits the fission that is going on. So to put together what we studied so far, we understood that JC10 indicated that the mitochondria was definitely undergoing depolarization in ericoline group. In case of the TGF beta and A plus T group, it showed healthy mitochondria. Then in terms of structural changes, we saw by confocal microscopy that the ericoline group showed us punctate mitochondria, which was indicative of fission, and the TGF beta and combination group showed us predominantly fused mitochondria. which were long and complex in nature. When we studied the markers of fusion and fission, we found that ericoline group showed us highest expression of the fission protein DRP1 and least expression of fusion proteins. So it exhibited a predominantly fission like condition going on in the mitochondria. In terms of TGF beta, it was predominantly fusion and very low fission. And in terms of the combination group, it is both. The fusion is going on high, at the same time, there is also fission going on. So we know that each of the different chemical is inciting a different change in the mitochondria. And in mitochondria, it's never completely fission or completely fusion. It's always a predominant phenotype that we would be seeing. To further confirm these changes, we did a seahorse respirometry experiment. This was conducted at the Roswell Park Cancer Institute. And here we found that it was aligning with our results of fission and fusion, where ericoline groups showed us the maximum proton leak, reduction in coupling efficiency, and reduction in spare respiratory capacity. So far we definitely know that fission fusion changes are going on in the mitochondria. And as we had seen before, when there is fission, there is going to be a change in the energy metabolism. That means that in case of fission, there's going to be glycolysis that you could expect. And we used hexokinase 2 as a surrogate marker for assessing glycolysis. And in case of fusion, there would be an increase in the mitochondrial capacity or in transcription of mitochondria. So to assess that, we use TFAM or transcription factor of mitochondria. And when we did an immunofluorescence assay, we found that the TGF beta and the A plus T groups had maximum expression of high levels of TFAM. All the other groups had lower expression. This meant that there is increased transcription in the TGF beta groups, which is aligning with our previous understanding that there is fusion and there is increase in the mitochondrial biogenesis. To further confirm this, we also did a PCR and we found that the ericoline group had reduced TFAM expression, whereas the combination group and TFAM, TGF beta group had higher expression of TFAM. Like I mentioned before, to assess fission, we used hexokinase, and as you can see, a marked increase in the hexokinase expression could be observed in the ericoline treated group, which meant that distinct change in the energy metabolism is also going on now. So, in the start, I mentioned that there are phenotypic changes that couple with these energy changes, right? So, to assess the same in our cell lines, we used markers such as vimentin, alpha SMA, desmin, and myosin, and we found that in the in the treatment groups, there was definite change in the ASMA expression, which meant that the fibroblasts are definitely differentiating to myofibroblast. What was interesting is that very few number of cells in the A plus T and TGF beta group also showed us desmin expression. However, this was not very significant. And all the remaining groups did not show us any differentiation or other cytoskeletal markers except vimentin. Now, interestingly, in our confocal microscopy results, we found that vimentin exists in two forms, the filamentous form as you see here, and as disrupted aggregates that are seen throughout the cytoplasm. Now, why was this important is because vimentin not just helps in the structural support or positioning of the cell organelles, but it also co-localizes with the mitochondria. And so we wanted to assess how it is relevant in our study groups. And in our study groups, in case of TGF beta, a distinct fibrillar vimentin could be observed. And in ericoline plus TGF beta group, the cytoplasmic extensions showed us fibrillar vimentin, whereas the central area, in case of the combination and ericoline groups, was predominantly in the form of aggregates. So this is probing us to think further whether vimentin is actually supporting mitochondria or vice versa. And so we looked at some of the studies that existed in literature, and we found that in one of the study by Tang et al., um, They showed that besides microtubules, vimentin overlaps with mitochondria more. It sort of maintains integrity and morphology of the mitochondria. And when they depleted vimentin, they found that the mitochondria changed into a more fission like phenotype, which meant a fragmentation of mitochondria was taking place. And this is exactly what we saw in our ericoline groups. So furthermore, we also found in their paper that there was an explanation regarding how vimentin supports cell survival, or how does it modulate apoptosis through this change. And this aligns with our existing model. Post understanding the changes that happen in the cell lines when you treat them with different groups, it was very important to validate the same in clinical samples. And so first we started with assessing the myofibroblast immunophenotype in OSMF samples, and we found that in serial sections when we stained the tissues, vimentin expression increased as the grade increased. This overlapped with the expression of alpha smooth muscle actin, which meant that definitely the SMA positive myofibroblast were increasing. Next, when we checked for desmine, very few of these fibroblasts showed expression of desmine, and even little in case of myosin. But we also found some epithelial expression of these proteins, which could have been indicating EMT, but we have not probed further. Now, next, to correlate the TFAM mediated changes in clinical samples, we had to check whether TFAM expression was also upregulated in the advanced grades of OSMF or progressive grades of OSMF, because we saw in cell lines it was the case that TGF beta and combination group had maximum TFAM expression and fusion, which was indicative of survival. So, to see whether this also takes place in OSMF tissues, we stained the tissues with TFAM, and we found that in case of myofibroblast, a definite increase in the juxtaepithelial and the deeper TFAM stained myofibroblast could be observed. And in case of muscle, increase was seen, but in the advanced group where there was a tendency for muscle degeneration, this TFAM expression was reduced. So this also aligns with the existing knowledge about how TFAM plays a role in maintaining the muscle structure and function. So some of you would ask me, how did you check whether these TFAM expressing cells were definitely myofibroblast? And there's no definite possibility to this, but we used serial sections and we checked for the same areas, and we found that co-localization was observed between these two, and so we could put forth that yes, probably the TFAM expression does increase and they are seen in the myofibroblastic cells. Now, the last thing would be to actually validate whether TFAM plays a role or not. So we again went back to our cell lines and we used KT, which is an inhibitor of TFAM. And we found that when you add KT in the combination group of A plus T, a marked cell death was seen. Now, why would this happen? Because TFAM was high in A plus T group when there was increased survival, right? But as soon as you put an inhibitor of TFAM, the cells start to die. This definitely showed us that there is some cell death that can be brought about in these myofibroblasts using KT. So to summarize this work, we studied the interplay of agents such as ericoline, TGF-beta, and we checked for the functional processes that could be running to maintain the mitochondrial dynamics, and how this rendered the condition irreversible. To put forth a model, ericoline can do two things. One, it induces fibroblast cell death because of the toxicity of ericoline. And next could be that subtoxic levels or ericoline that causes upregulation of TGF beta in the epithelium could bring us fibroblast survival as we observed in our cells. In early or acute phase, this TGF beta could be modulating metabolic changes through TFAM that brings about increased survival of these cells. And these cells, when they undergo phenotypic changes, that is, they start expressing stress fibers, high amount of vimentin and ASMA, their survival and function both increases, and they start depositing a lot of collagen, which meant that the whole process could be supported through energetic pathways that run in the mitochondria, and hence thus fibroblasts that survive are the ones that are causing chronic fibrosis or irreversible fibrosis. So to conclude, the stable, synthetically active fibroblasts appear to be reprogrammed via TFAM driven mitochondrial changes. This work proposes this model wherein a possible relationship between areca nut and TGF beta signaling can be observed in the progression of submucous fibrosis, especially mediated through mitochondrial changes. And this work would not be possible without the support of my mentors. This was a collaborative work that took place at the University of Buffalo at Dr. Arani's lab. And along with the lab members, we also collaborated with the Roswell Park Cancer Institute and, of course, at the Department of Oral Pathology at KLE, where the clinical samples and the other experiments were taking place. And I'm extremely grateful to Dr. Atanu Basu and the ICMR NIV group of EM and histopathology, and especially the grad students, Dr. Nitali and others, who helped me learn all the cell handling experiments and so on. And with this, I just want to conclude by saying that alone we can do so little, but together we can do so much. So, all questions, all collaborations are welcome. And thank you so much for your patient listening. Thank you.
Yes, thank you. That was indeed very, very interesting. And of course, oral submucous fibrosis is always a very interesting topic as it is. It is still a great unsolved mystery, but I guess we are getting closer.
Hope so.
Yes. So anyway, we have so far not got any questions. So in the meanwhile, while everyone, please remember to add in your questions and comments in the chat. In the meanwhile, I'll make a couple of announcements. So first is that we have the first diagnostic table slide 360, of course, taking after our name. That is scheduled now for the 6th of December. The first one is on salivary gland pathology by Dr. Nagamani Narayana from the UNMC, USA. So the interesting part about this are two things. One is, of course, that we are sharing the slides. In fact, the slides are already shared, and so you can prepare. You can, come up with your own diagnosis, have a differential, so that when the discussion eventually happens, it really sticks. And the second thing is, I think there's nothing more lovely than getting books, and we are giving away two books, thanks to Professor S.R. Prabhu, who is giving two of his books, one co authored by Dr. Narayana, and the other one is just a pathology book. So these are going to go by a lucky draw to everybody who registers on that day. So this is a great thing. One is pathological basis of oral and maxillofacial diseases, and the other one is oral histology and oral histopathology. So it's a great opportunity, not just to learn, but possibly to get a wonderful book. Do join us. It will be great to have you with us for this first ever slide 360 discussions and series, although we will have them every 2 months now. So the next one will be in Jan. And also, I will make an announcement of our upcoming and the last session for 2025, because after that, we go on our December vacation. The second 2 weeks of December, we are on vacation. This is by Dr. Paras, and he is going to talk about OPMDs and their management. Again, he is from the US. I do hope you will join us. Right. So now let's come back and see what we have discussion wise. So I still don't see any questions. What about you? Tell us what you're going to do next with this result.
So, with this, we have applied for a different. We are looking at the therapeutic application here, basically, to be open. So, we are trying to target these surviving myofibroblasts. So the problem here is they have different phenotypes. So we are still trying to understand how do we target it in such a way that these specific myofibroblasts undergo apoptosis. And that's why OSMF is very difficult to treat clinically as well, and it comes back because the cells are always going to be there. Like, how do you get rid of them? So, and the energetic pathways are supporting them. TGF beta, like we know in the oral cavity, it's already there. Plus, ericolin is causing some more. So, in a preconditioned environment, it's flourishing, it's growing there. The only way is to stop the habit or look at therapeutic options which can be so targeted that you can help them undergo apoptosis. So, that's what we are trying to get at. Like,
Yes, that is true. It has always been a great mystery how, specifically in the oral cavity, where we know the tissue has a tendency and an ability not to fibrose,
exactly.
not to get scarred, because it's very close to the fetal fibroblast. But how it goes on then to go through in, I mean, the exact opposite end is oral submucous fibrosis. So it's always been, I guess, that we knew at some level that the original cells have to either be killed, destroyed, and therefore the next generation is not having the original phenotype, or then something actively changes their phenotype to the next before it can actually go on to become fibrosis. So it's like that intervening step. And if we can, maybe interrupt that step,
Exactly.
maybe we can prevent.
And even through our work, what we understood is that probably if you get it at an early stage, only then even targeting would be effective. So it is difficult, like when patients come with extremely reduced mouth opening, and you will see some or the other white lesions, because as you saw earlier as well, the glycolysis, ericolin starts promoting glycolysis. It starts making our environment where this plastic changes could happen in the epithelium. So, and probably TGF beta is rescuing these changes in the fibroblasts, and that's why we don't see fibrosarcomas as such. But I don't want to extend or think too much beyond. Like, science is
Yes,
very tricky. If I say something now, but yeah, so
yes, I know. But it's, I always think, of course, essentially we cannot put down anything unfounded in writing, but
exactly,
which is why I like discussions. We can do say a lot more in a discussion than you would ever put into a paper or into a textbook, because
exactly.
finally this is discussion. It's just lateral thinking. We're not saying anything is proven, we're just thinking what next, and you got to do some amount of lateral thinking. So, among our audience, we have Dr. Hazare, who we know, of course, is one of our oldest experts on oral submucous fibrosis. Then let me tell you who else is there with us. Dr. Opat. Oh, that is Dr. Prasad Harikrishnan is there. Dr. Punya is there. Dr. Shrikant is there. Dr. Bhuvan Nagpal is there. Yes, hello everybody. And I know you're seeing me looking there for the result, for the comments, because for some absurd reason today our connection seems to be partial. So I'm not seeing your comments here. I have to look at my other screen.
Oh,
And yes, and
I was
funnily
thinking
enough, we
either
were
they didn't
discussing about it
understand,
just before.
and I was thinking either they didn't understand anything.
No, 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 no. No, and in fact, people are there. I know it looked from here like no one was listening, but they're there. They're there. Don't worry. So, and it's lovely to have everyone here. But if you would like to put in any comments or questions, Dr. Punya is saying hi. Hazara sir is saying thanks. And
So Hazare sir has worked, like I and Hazare sir shared a lot after my PhD. Like, he was examining my PhD, and I was very happy about that part. And then we discussed a lot about submucous fibrosis. We are writing chapters together, and sir has found cases of PVL that he followed across a very long time span, where they were in the background of OSMF. So we have come across dual pathologies. You'll see, I think there's a letter by Dr. Sarotes or some group which has also spoken about how these dual pathologies are important in OSMF. So there's a lot to be explored in OSMF, and
True, true. Cool. I think everyone is still sort of absorbing all that. It is going to take some time. I know it's going to take some time, but luckily your paper also is coming out. The publication also is
yes,
coming out, so they you be able to also read it besides watching it here.
yes.
So, do you want to share anything before we go on?
No, I think this was one of the early efforts, and I hope more people continue to chase this mitochondrial reprogramming in oral submucous fibrosis. And I think the only way to go about it in India is by collaborating, because when I started, I mean, hats off to Kale madam, because she was very persistent and she reached out to so many people, because we didn't have all the instruments there, but she reached out to so many people, from where we found the ICMR collaboration, we found Dr. Arani's collaboration, and so on and so forth. So the department has immensely supported this work, and I think collaboration is the only way you can foster science. So I hope most people, if nothing from this talk, they should at least take this thing in mind, that they should collaborate. You may fail, you might not get the results that you're expecting, but collaborations could give us some results in the future that would help us. So definitely.
Totally, totally agree. Yes, absolutely. So then now let me just share with you your little certificate to say thank you so much
Thank you so much, ma'am. It was
for
great. Yes.
sharing your wonderful work, and it's a very valuable work, and I wish you further success going ahead, and hope you can take this somewhere, and we will be very proud to have had it here. Yes,
Thank you, ma'am. Thank you so much.
you are most welcome. And of course there's a lot of comments about good presentation that's coming up there.
I
Yes.
mean, yeah, feel free to reach me directly if you have any questions. I'll be happy to support you with even techniques if you need any assistance. So that's a given.
Yes, Dr. Karishma is there on LinkedIn for anyone who doesn't know her directly. And you can also reach her through me if you ever need to. But anyway, she's easy to find, not to worry. Okay, folks, I guess we can say bye bye. So,
Thank you.
bye. See you. Everybody stay well, stay healthy, stay curious, and keep learning till we meet again. Bye bye.
Thank you.